Okay.
By the way, leading our working group in
Yeah.
UAE.
Okay. I
Heart
was
failure.
told 15, now 12, and you wasted 2 minutes already. Okay. Thank you for the opportunity. Thank you, Prof. Shihab and Rosanna, for inviting me. I don't think I'm going to tell you anything you don't know, really, but I'll try to highlight some controversial things and differences between European and the American guidelines or rules in this use of ARNI SGLT inhibitors. So I'll talk about the role of ARNI in HFrEF, role of SGLT inhibitor in HFrEF, and then role of ARNI in HFmREF, HFbEF, SGLT HFbEF, and guidelines what it says, and if I have time, acute decompensated heart failure. So in HFrEF, you know, the paradigm study, this is just remind you, is the largest morbidity and mortality trial. If 8,000 patients, you know, sacubitril/valsartan versus an active comparator in enalapril, which already been shown to be very effective in HFrEF. Not only it's met all primary endpoints, reduce, you know, cardiovascular death, heart failure, hospitalization, sudden death, hospitalization, all-cause death, everything. Give us an extra 20% reduction in the composite endpoint in top of or in addition or to the ACE inhibitors. So you know, the jury is sorted regarding the ARNI for HFrEF, protects your kidneys, so your GFR is likely to decline if you are an ARNI compared to an ACE inhibitor. It's actually safer. You're less likely to damage your kidney. You're less likely even to have hyperkalemia if you use ARNI compared to enalapril. Again, the SGLT2 inhibitor story, you already heard it. It came from mandate of the FDA to test these drugs in high-risk diabetic, and they proved to be not only safe for MACE, but also they reduce heart failure. And now they are in class 1 indication to reduce risk of heart failure in high-risk diabetics. In the treatment of HFrEF itself, the DABA came to the front first in 2019 with the DABA heart failure trial in diabetic and non-diabetic ambulatory patients. The trial missed the primary and secondary endpoints, reducing cardiovascular death, heart failure, hospital, and worsening heart failure, not heart failure hospitalizations, which is more wider inclusive. But anyway, 26% reduction. Benefits seem very early. Start your drugs early, please. 18% reduction in cardiovascular death, 30% reduction in heart failure hospitalization. I think you know all this. The EMBER came 2020, a year later. Very similar design. EMBER versus placebo in diabetic and non-diabetic HFrEF patients. Significant reduction in composite endpoint of heart failure, cardiovascular death, and heart failure hospitalization. Significant protection of your kidney benefit better. A reduction of the slope of your eGFR by half if you are on these SGLT inhibitors. So the guidelines for 2021 European, 2022 American basically incorporated the ARNIs as well as SGLT inhibitors, put them in class 1 recommendation to start as early as you can. So they both agree on this, in addition to the MRAs and beta blocker. The European kept ACE inhibitor as class 1A recommendation, but gave ARNI class 1B recommendation, not class 1A recommendation, and downgraded ARB from class 1A to class 1B. American, however, gave ARNI class 1A recommendation. So just there'll be more controversy, more differences when we talk about the HFrEF, HFbEF later on. These are guidelines. And said use ACE inhibitors only if you cannot tolerate, you cannot afford ARNI for the HFrEF. Okay, so the slight difference here. And as we mentioned, SGLT inhibitors, you can use them to prevent heart failure in high-risk diabetic, as we discussed all day. Now, moving on to maybe the more controversial, the HFmREF, HFbEF. Now, in the ARNI, because I'm talking about ARNI SGLT inhibitors, you know you heard about the Paragon trial, huge trial, nearly 5,000 patients, ambulatory HFmREF, HFbEF, eGFR more than 45%. Now the trial there was a reduction of the composite endpoint of heart failure, hospitalization, cardiovascular death by 13%. This just missed the statistical significant p-value came at 0.059. So sounds negative from what you say as a primary event. However, if they added or included the urgent heart failure visit to the heart failure hospitalization, which they are collected, but they were not in there as a primary endpoint, the study would have been positive with the p-value of 0.04. So if you look at from prevention of the combination of cardiovascular death, heart failure hospitalization, and urgent heart failure visit, patient needs to attend because of worsening symptom, getting a diuretic but not being admitted, the study would have been positive. So you can obviously, this is rather a thought generator or just make you think rather than say this is a negative trial. There are things to read here. Now, as you heard, the HFpEF patient, you see them. They are really, these are the one that full of comorbidity, poor quality of life. I'm sure you agree with me. Your HFrEF patient tend to have better quality of life than the HFpEF, just because they tend to be obese, hypertensive, CKD, anemic, wheelchair-bound, obstructive sleep apnea. But the quality of life improves significantly if you give them ARNI. And the NIHA class improve as well. You protect their kidneys if you give them secretory valsartan compared to valsartan. And if you look at those with ejection fraction up to 57%, and this was a pre-specified subgroup, all the patients with ejection fraction up to 57% do benefit if you look at them as subgroup. There's 22% reduction in the primary endpoint. And women who continue to use more than 50% of the study group benefit across all ejection fraction. And women on sacubitril valsartan and the Paragon do much better than women on valsartan and do better than men regardless of the treatment they are on, whether it is primary in the reduction in the primary composite endpoint or the heart failure hospitalization. And if you put all data together, the Paragon and the Paradigm try to look at the effect of ARNI across all ejection fraction, which work was done by Jack McMurray and his group. So in specified pool analysis, you'll find that all outcomes reduce significantly with the use of ARNI across all ejection fraction. Those the blue bars you see on the right side graph are all to the left. So all the outcomes do improve significantly with the use of ARNI across all ejection fraction. Now, this graph also shows you, obviously, the benefit is more if you lower your ejection fraction, the more the benefit. And the benefit extends beyond the 40-45%. It goes up to nearly 55-56%. And in women, it goes all the way even to a normal ejection fraction. So the benefit in women with the ARNI goes to ejection fraction even to normal ejection fraction. Now, this is not only seen with ARNI, it was seen also with the candesartan in the CHARM trial and the MRAs. So they benefit, yes, best in the low ejection fraction, but it goes more than just 40-45%. It goes up to the 55%, whatever. If you look at all group, and in women, again, the benefit extends even beyond that to normal, not only sexually with all the RAS inhibitors. So you cannot just write them off. The FDA, so that's not me saying this, the FDA has approved or expanded the indication of use of ARNI to label it not without states to recommend to be used for heart failure without specifying the ejection fraction, but highlighting that the benefit will be more and best with those subnormal ejection fraction. And that label actually has been approved or adopted by the UAE. Okay? Now, SGLT2 inhibitor story is probably simpler, easier, less controversial. Came with the EMBRA Preserve first in 2021, just after the European Society of Cardiology guidelines came out. And you know that the trial looked into patients with ejection fraction more than 40%, EMBRA versus placebo. Trial was positive, met its primary secondary endpoint, reduction in cardiovascular death, heart failure, hospital by 20%. Number 331, protects your kidney again. And this benefit is seen in diabetic and non-diabetic across all ejection fraction, although the benefits in the EMBRA Preserve tend to attenuate and the ejection fraction near the above 60%. The DELIVER was a bigger, larger trial. This is the largest trial for SGLT2 inhibitors and HFpEF, more inclusive, because 16% of patients were actually just being hospitalized or just being discharged, and included 30% were ejection fraction more than 60%. 18% were those with what we call heart failure with improved ejection fraction, which never been studied with this magnitude before. So it's largest study, positive, meets all primary and secondary endpoint, reduction of cardiovascular death and worsening heart failure, benefit consistent across all the groups, diabetic, non-diabetic, with no attenuation. Those with the improved ejection fraction did benefit. Those with the recently admitted or discharged benefit. Those with CKD or no CKD, they all benefit. And if you put the data both together, this slide was shown by Professor Rozzano before, you get significant reduction in combination and also even in the cardiovascular death without attenuation, and much significant improvement in the quality of life. Okay, so I will skip this for the sake of time, and I'll take you to the guidelines. So what the guidelines say, this is the American guidelines 2022, before they delivered, we had only the Emperor Preserve, give the SGLT2 inhibitors class 2A, which obviously should be class 1 now with the deliver, and also for the HFmREF, give the ARNI class 2B as well as the MRA and the beta blocker. But also they give them class 2B and the HFpEF along with the MRA and R. Not ACE inhibitors, not beta blocker, but according to the American, you have class 2B indication to use ARNI, MRAs, and R. And May this year, the American Society of Cardiology produced this consensus decision pathway in the management of HFpEF. Please don't cut me off. Please give me 2 minutes. Don't cut me off. Okay, it's a big topic. Anyway, so what it says to you really, first line therapy, or there comes class 2A, or there should be border with the green, should be class 1, SGLT2 inhibitors. But then obviously diuretics to treat congestion, but also MRAs if you are a woman or if you're a man with ejection fraction less than 60%. Similar thing for the ARNI, and the R to be used only if ARNI are not feasible or expensive or affordable. Or, so you have a rule for SGLT2 inhibitor. Number 1, diuretics, MRAs, ARNI. The European, as you probably heard, for the HFmREF, gave obviously SGLT2 inhibitors class 1, rightly so, and class 2B recommendation for the ARNI, MRA, beta blocker. But for the HFpEF, only obviously diuretic, treat the underlying cause appropriately, and the SGLT2 inhibitors. Did not recommend use of other RASI because the trial did not meet their primary endpoint. Okay, but the American says something different. For the acute heart failure, you probably heard about the Pioneer, which is showed that the ARNI are safe and effective in HFrEF. But a quick word about the paraglide heart failure, which you looked at the HFmREF, HFpEF, ejection fraction more than 40%, admitted or recently discharged, and look, the primary endpoint to reduction in ProBNP, which was achieved. The secondary endpoint, reduction in the outcome, numerically was less, but did not achieve statistical significance. And obviously, we know the SGLT2 inhibitor, the EMBULSE trial, which is safe, effective, the EMBA, and it is recommended. And thank you.